Welcome everyone. Let's jump in. Okay, so we've got quite a few people. Oh wow. All right. So I will sort of explain what the mission is for Migraine Headache Australia, and it's really threefold. We aim to provide trustworthy and reliable information, and primarily we do that through our website and webinars like this, and the articles on our website are for the most part medically reviewed as well. So we have a wealth of information there. We fund research into migraine and headache, and we try to fund at least one migraine headache research project each year. And we also advocate and support people living with migraine and headache disease or diseases. And we do that in a number of different ways as well, which I'll talk about, which may involve influencing policy and decision makers and a range of other things too. So before we jump in, we're highlighting each night or each session a different aspect of what we've been doing this year. And last night we spoke in detail about our media, and we also covered some research. And tonight we'll go into some of the articles that we've been producing and new resources. And so you can see here that we've added 15 new articles this month. I'm sorry, this year, and many of them have come online just in the last 2 months. And so there's a number of new treatments. You can see here rizatriptan, zolmitriptan. These are types of triptans, and we've also sort of added to the list. You can see in the right-hand side that we've already done sumatriptan, elatriptan, and a number of other treatments, such as Nurtec and neuromodulation devices. We've also done other articles around migraine in the workplace, living with migraine symptoms, strategies to help prevent the progression from episodic to chronic migraine, understanding the psychological impact, teens with migraine, which is actually aimed at teenagers and written for teenagers specifically to learn. And we also covered a few more types of headache disorders, such as cluster headache, sinus headache, ocular migraine, hemiplegic, abdominal migraine. So there's a great number of resources. You can check those out. You can search on the website, or you can find them by navigating to the different sections in the menu. And we hope you find those helpful. They've all been medically reviewed, and many of them actually have been medically reviewed by our expert tonight, Dr. Emma Foster. You are in the right place if you have migraine or headache. If you are a parent, partner, or caregiver, if you'd like to connect with others, or if you want to ask a question, you are in the right spot. We are going to be covering many aspects of those. And I'd also just let you know that we do have a peer support group on Facebook. I know that Facebook isn't necessarily everyone's favorite tool, but if you are there, if you do have a certain level of isolation that we spoke about last night that a lot of people do, and you sometimes just want to bounce something off others or support others or receive support, then that might be a nice opportunity for you to get more involved. And I'd also like to thank our sponsors for this week who've made these webinars possible and allow us to reach many more people than we would otherwise do so. So big thank you to AbbVie, to the Brain Foundation, to Pfizer and Lundbeck. Now, to introduce our speaker for tonight, Dr. Emma Foster. She is a consultant neurologist and a headache specialist. She's a member of the Australian New Zealand Headache Society, and she has a deep expertise in epidemiological outcomes and cost effectiveness of research methodologies and, of course, migraine. She's a published author in leading international journals in neurology. She's presented her research at the prestigious American Academy of Neurology podcast series. She's the recipient of several research grants and scholarships during her PhD candidature, including an NHMRC postgraduate scholarship. Suffice to say, she is a headache expert. We love working with Dr. Emma Foster, and she's been instrumental to the development of resources and many other aspects of our partnership with the Australian and New Zealand Headache Society. So I am thrilled to welcome her. We also have in the comments, in the webinar, Anik Grundy, who is our grants program manager and digital lead. She is a employee of the Brain Foundation and Migraine Headache Australia, and she has also been behind many of the resources and tools. And you can say hi to her in the chat. she'll be sort of taking care and helping answer questions and supporting the webinar behind the scenes. So big thank you to Anik. And for those of you, if this is your first time as well, I am Carl Cincinnati. I should probably introduce myself as well. I've lived with migraine. I work with Migraine Headache Australia and the Brain Foundation, as well as a number of other coalitions and global patient advocacy efforts, such as the Global Patient Advocacy Coalition and the World Health Education Foundation. And I'm a member of the International Headache Society. I'm also a founder of the Migraine World Summit, which is a patient online event for people living with migraine and headache disorders. And whenever I get the chance, I speak out about migraine and have spoken nationally and internationally on TV and radio. And you can see some of those images to the left about some of the work that we're doing. And whilst there's been sort of lots of opportunities, there is still a long way to go, as we know from some of the recent research. So with that, I would like to transition now to our presentation for tonight that we'll hear from with Dr. Emma Foster.
Hi, I'm Dr. Emma Foster, a neurologist at the Alfred Hospital in Melbourne and an early career researcher at Monash University. I'm pleased to present to you treatment strategies and combinations for Migraine and Headache Awareness Week 2025. And thank you very much to Migraine and Headache Australia for the kind invitation to speak to you. I'd like to acknowledge the Boonwurrung and Wurundjeri clans of the Kulin Nation, who are the custodians of the lands and waters on where I am today, and I pay my respects to elders past, present, and those joining us this evening. These are my disclosures. So the funding basically is for investigator-initiated grants to do research, and there's some speaker honorarium as well. As a reminder, this presentation is for informational purposes only. It is not professional medical advice. And anything that you see here tonight, I'd encourage you to take to your clinicians to have a further discussion. Okay, so this talk will be in 3 parts. Lifestyle modifications, acute or rescue treatment for migraine attacks, and preventers or prophylaxis for migraine. So let's start with lifestyle modifications. I split it into 4 sections: identifying and managing triggers, mindfulness, biofeedback, and physical exercise. So let's start with identifying and managing triggers. These are some of the things that people often relate to their migraine attacks. The first one is hormonal changes for women. Often, women experience their first migraines around the time of puberty when their menstrual cycle starts. Often, around the time of the period, women do find their migraine worsens. During pregnancy, migraine might change substantially. And in the perimenopausal phase, which is the few years prior to and around menopause, migraines often can change as well. Each of those times in a woman's life is when there's great fluctuation in hormones, particularly estrogen and progesterone, and that certainly can be a trigger for migraine attacks for people living with migraine. Stress is certainly something people come in tell me about in clinic as a clear trigger for their migraine. Stress is often we think about sort of emotional stress and cognitive stress, but stress can also be physical stress, for example, overexertion or being unwell. Perhaps paradoxically, stress relief can also cause migraine or migraine attacks. Often people say they were extremely busy at work but powered through, no migraine, sometimes a bit of a surprise given the pressures they were under. And then the project gets submitted or they go on leave and suddenly they get a terrible migraine attack. People often report too little sleep can cause migraine, but too much sleep also can sometimes be a bit of a factor. And there's often dietary triggers that people have identified. These vary between people. Some people don't have any triggers, some have a few. Common ones include dark chocolate, red wine, strong cheeses, meats with preservatives, MSG, gluten, citrus fruits. Alcohol can also be associated with migraine attacks. One of the things that sort of underpins all of these triggers is the need for consistency. Migraine likes consistency, likes waking up the same time each day, going to sleep the same time each night, eating at the same sized meals about the same time every day. So one of the things that people sometimes monitor who live with migraine is just trying to make sure as much as possible there can be stability in a lot of these factors in their life to help reduce the chance of a migraine attack. Here are some other things that can trigger migraine: physical exertion, bright lights, particularly fluorescent lights, and ergonomics is really important. A lot of people have a bit of a hybrid work situation these days where they work from home some days and work in the office other days. And having a good setup with your desk, your chair, your keyboard, the height of your screen, and whether your screen has some glare protection can make a big difference to how you are at the end of the day in terms of where you are tracking with migraine attacks. Because there are so many variables that can drive migraine attacks, it can be helpful to keep a headache diary. We certainly need this in our clinics to track how people are going. Headache diaries can become quite complex given how many variables people might measure. So if it feels a little overwhelming to start with, I'd suggest you do a traffic light system. Each day of the month, at the end of the day, you colour in whether your day was a green day, which means you were crystal clear, completely free from migraine symptoms. If it's an orange day, it's a day where you definitely had some symptoms, but you could get on with everything you needed to do. And a red colour day is one where a migraine attack was quite severe and it stopped you from doing what you needed to do. I'd also recommend you write down rescue medications, so just whether or not you needed something to help you with the attack on that day. And if you're a person who's menstruating, to also note down when your periods were happening. And if you can do that for, say, 3 months and take that to your clinician, that can be a really helpful guide to see if there's any cyclical pattern to your migraine, how it relates to your period, and you can add in additional details as well as you get comfortable with filling in the diary. Mindfulness. So this can be a very strong and effective tool for migraine management. Let's start with what it is. It's being present, paying attention deliberately on purpose to where you are right now, and it's non-judgmental. Some people liken it to being on an imaginary train platform, and you're watching your trains, which are your thoughts, coming in and out of the station. And your job is just to observe. You're not there to judge your thoughts or engage with your thoughts or argue with your thoughts or try and work out a plan to deal with your thoughts. It's just to let them be. The purpose of mindfulness is really to make that space between you and your thoughts, and so be aware of what is coming through. Not trying to stop it, but not getting on board, and creating that space between what your response is to what your thoughts are and what's going on around you. And there's power in creating that space. What mindfulness is not, it's not trying to relax. Mindfulness is a workout. Trying to sit and be with your thoughts and be present is hard. You need to constantly bring yourself back because our minds wander every few seconds during mindfulness. It's like an exercise. You have to make sure, where am I now? What am I thinking about? Am I in the present moment? And sometimes focusing on your breath brings you back to where you need to be. So it's definitely not trying to relax. And sometimes mindfulness can be frustrating. You can be doing mindfulness several times a week for months, and you think, oh, I'm not improving. I'm still, getting wound up in my thoughts. But if you think about it as like we do physical exercise, you have some good days. You have some days where you finish your workout and you think, oh, gee, that felt really hard. But that's the important thing. If it felt hard, you were really doing it very well. Mindfulness is not withdrawing or escaping from life. You're very much in it. You're making an active effort to absorb and be present with the present time. And it's not emptying your mind. Mindfulness is not trying to block thoughts or delay them. It's letting them come through. The important thing is not getting on board with your thoughts and just letting them pass. Does it work? So this was a randomized control trial, which is one of the most robust scientific trials we can put together. And the researchers looked at a group of people living with migraine who either underwent mindfulness-based stress reduction or regular headache education that you'd receive in a clinic setting. And they found no difference between the groups with regards to improvement in migraine frequency. However, the mindfulness group did report improvements in their disability, quality of life, self-efficacy, pain catastrophizing, and also improvement in their depression scores. But the general conclusion was that more study is needed. Biofeedback. So this is a technique that helps people control certain bodily functions that can be linked to migraine onset. So, for example, a sensor is popped over muscles, and people can then, with biofeedback, practice relaxing their tense muscles in their forehead, jaw, or shoulders. And it's done with trained specialists and specialized equipment, usually several sessions every week for a few months, and gradually people begin to be aware and able to overcome some of these bodily functions to reduce the chance of migraine attacks from occurring. Does it work? So this was a systematic review, which basically means the researchers have gone in and analyzed every paper that has been published in this area and synthesized the results. So the researchers found that biofeedback is effective as an intervention for reducing migraine headache frequency and severity. But it's not more effective than pharmacotherapy, medications, or cognitive behavioral therapy. And there just were not enough data to see if it would help reduce the need for analgesia, which is pain relief, whether it reduced number of healthcare visits, and whether it could impact people's anxiety, depression, or quality of life. So more study is needed. Physical exercise. So this is a clinical practice guideline published a few years back by one of our leading headache journals worldwide. Again, the group of researchers had a look at all evidence regarding exercise and its effect on migraine. And they found that there was moderate evidence to support aerobic exercise and yoga on improving migraine symptoms, disability, and quality of life, and limited or weak evidence to support relaxation techniques, HIIT training, low-intensity continuous aerobic exercise, Tai Chi, and resistance exercises. And those exercises were found to improve migraine symptoms and disability. It should be said that everyone is individual, and you might find something on that level C list that actually works extremely well for you and your migraine attacks. So I think this is good background information, but just to be mindful, it might not apply directly to each individual. On to acute therapy, or the therapy we use at the start of a migraine attack. Dividing this into the non-pharmacotherapy options, pharmacotherapy, and non-invasive neuromodulation. So non-pharmacotherapy includes cold or hot packs on the head and neck, or wearing a migraine hat, which can be put in the fridge and then popped on your head, dark glasses or earplugs to reduce this sensory stimulation, essential oils or mint or tiger balm, gels and rollers applied to the temples, meditation, breathing exercises, relaxation techniques, pet therapy and support animals, and acupressure and self-massage can all help people living with a migraine. So pharmacotherapy, so that's medications taken at the start of a migraine attack. So I've divided them into a few subcategories. One of the important things before we discuss these medications individually is just to recognize the concept of medication overuse headache. That's a headache that can come on if people use these rescue therapies regularly. The body builds up a tolerance to it, so people find it becomes less helpful and the effect lasts a lot less. And then when the medication wears off, people often get a nasty rebound headache that is even worse than the migraine attack they're trying to treat. So one of the key points about these rescue therapies is just to be mindful how often they're used to try and reduce the chance of getting a medication overuse headache in addition to the migraine. So simple analgesics, paracetamol, ibuprofen and aspirin can be bought over the counter or at supermarkets to use no more than 3 or 4 days a week. Triptans are prescription medications, although you can get small quantities directly from a pharmacist. Their names include sumatriptan, rizatriptan, elatriptan, zolmitriptan, naratriptan, and recommended to use no more than 1 to 2 days a week. Gepants are the newest class that we have in Australia for acute management of migraine. The specific one we have here is rimegepant. Unlike the simple analgesics and the triptans, Gepants can be used both as an acute therapy, but also regularly as a preventer if taken each day. One of the major barriers to accessing rimegepant is the cost. It's not on the PBS and it costs around $30 a tablet. In addition to addressing the pain, antiemetics, which is used for the nausea that people can get, it's a very important part of managing the acute migraine attack. Some of these medications include metoclopramide, prochlorperazine, and domperidone, and you need a prescription for these too. Some good tips. People may respond very differently to different triptans. So if you've tried 1 or 2 and they haven't worked for you and your clinician suggests another one, I'd recommend giving it a try because you might be surprised the third one might actually work really well. A lot of these medications come in soluble preparations, like wafers that dissolve on the tongue, or tablets that disperse in water, or injectables. This can be very helpful because often gut absorption is reduced during a migraine attack, so it will help get the medication into your system a bit quicker. Combination therapies can be very effective. A typical one is people might have a high dose aspirin at the start of a migraine attack, and shortly thereafter, if the migraine attack's not beginning to improve, take a triptan. And it's important to treat early and treat hard. Frequently in clinic, I meet people who have lived many decades with quite bad migraine attacks, and they often have lived with a much higher degree of pain than the general population, and they will save their rescue therapy for particularly severe attacks and often wait hours before they think this is no longer manageable, I will take something. These medications work best when taken early. It's the way that the migraine attack evolves over time. There's different pathophysiology, which means different mechanisms are happening in the brain to drive the migraine attack between the early, middle, and late phase. And these medications work best in the early phase. Delaying taking them, although understandable, unfortunately will miss the most effective window when these medications can stop the attack or greatly reduce the intensity and duration of the attack. This is a really neat graph that was put together by Dr. Jason Ray, who's there in the picture and led the study, and also Dr. Elspeth Hutton, who's the director of the headache service at the Alfred. And I like it because it really illustrates neatly the different phases of the migraine attack. So I'll just take a moment to go through this. The prodrome phase can happen hours or days before the headache part of the migraine attack. People might feel fatigued, trouble with their concentration, irritable, they're yawning a lot more than usual, they might be craving food, particularly sweet food, they might begin to get quite sensitive to sound and light, they might feel quite stiff in the muscles, particularly around the shoulder and neck region. Then 5 minutes to about an hour before the headache starts, people may get an aura, particularly a visual aura, which is like some shimmering lights or some dark spots in front of the eyes, sort of a typical aura. People also might really notice that they're becoming quite sensitive to light and sound at that stage. And then the migraine headache starts, that throbbing, pulsating pain, worse on one side of the head than the other, might be accompanied by nausea or even vomiting if it's quite bad. People are very sensitive to light, to sound, to smell, to motion. They might feel very stiff in the neck, and they definitely find that any activity definitely worsens these symptoms. They just want to lie down in a dark, quiet, cool room. After the migraine attack finishes, which might be 4 hours or up to even 3 days, people will often have a post-stroke. They'll be fatigued, concentration will be shot, and they might have quite low mood. I like looking at it like this because the migraine attack often goes so much longer than what people might have thought. Often we traditionally think about just that middle section there, the actual headache, as being the migraine attack, but it actually includes days beforehand and maybe days after as well. Particularly, I think the prodrome phase is interesting. If you're sort of new to charting down your migraine diary, you might begin to think about just prior to an attack, did you notice yourself yawning more? Did you notice yourself having perhaps a craving for chocolate, or were you stiff in the shoulders and neck? Sometimes people put these down as triggers. The sweet food causes the migraine, or the neck stiffness causes the migraine, when in actual fact, these were the earliest symptoms of your migraine attack happening. Now, moving on to the need to go early and go hard with your triptans. This comes from a study, a prospective multi-center study, which again is a very robust study design. The investigators looked at treating people who took their triptans within an hour of the headache onset, which is the green arrow, and compared it to a group of people who chose to take their triptans later, more than an hour after the headache attack started. And there was a significant difference 2 hours after taking the triptan as to where people were at in terms of their migraine pain. The people who took it earlier were doing much better than the people who took it later. The researchers then got the group who took their triptan late and asked them to start taking it early, and they found that significantly improved people's pain 2 hours after taking that triptan. So I think that really sort of drives home that importance of taking that triptan as early as possible when the migraine headache starts. Now, there are some non-invasive neuromodulation options as well for migraine attacks. The Kefali is a band worn around the forehead, and it stimulates the first division of the trigeminal nerve. The trigeminal nerve is the major player in migraine and headache pain, and it pulls sensory responses from the face back into the brainstem. And so the Kefali works by having an electrode here that pulses and stimulates the trigeminal nerve. It can be used not just during an attack, but also you can use it daily as a preventer. Gammacore is a vagus nerve stimulator. The vagus nerve is a very important part of the parasympathetic nervous system. It runs from the brainstem down the chest into the abdomen, and it helps regulate or modulate pain. You need a prescription for Gammacore. You can use it at the time of the attack, but a bit like Kefali, you can also use it daily as a migraine preventer. And that will move us neatly into preventers. So we'll cover when to treat, natural therapies, pharmacotherapy, and advanced therapies. When to treat. So consider prevention if migraine attacks significantly affect daily life. These tips are from Professor Richard Stark. He's there in the picture. He's got some very good tips with his after his career with great experience in migraine. So when do migraine attacks significantly affect people's life? Really, people might have very few attacks, but they really have a profound impact. So we'd be looking to speak to a person then about preventer. On average, we feel about 4 migraine days a month is about the time when people really become quite impacted by migraine. You have to weigh up the pros and cons. Obviously, being on a medication can have side effects. There's costs involved. They can interfere with other medication that you're on. But we should also remember that some of these migraine preventers can have a significant improvement in people's migraine frequency, duration, and intensity. And also, side effects aren't necessarily bad. A lot of the migraine preventers were developed with a different indication in mind. For example, blood pressure control. So if you already need to be on a blood pressure medication, you could take the one tablet for your migraine and your blood pressure. The other thing is that benefits are cumulative and dose-related, which means that if you continue taking this consistently, evidence shows that you will get improvement over time. And the highest dose that you can tolerate, and there will be a dose that your neurologist or GP will try and target, often brings better effect than a lower dose. But of course, high doses often also come with more side effects, so there needs to be a balance struck. In terms of natural therapies, these are the 2012 guidelines from the American Headache Society and the American Academy of Neurology. No natural therapy has got a definite evidence for its effectiveness as a preventer. Level B evidence with probable efficacy includes magnesium and riboflavin, and level C evidence includes, which is possibly effective, is coenzyme Q10. Now, these are very recent 2025 evidence-based guidelines for the treatment of migraine. And I've done a screenshot of the authors just to show you how many headache experts from around the world were involved in looking at all the studies that discuss migraine preventers, and also interpreting this information with their vast clinical experience. And I've highlighted here 2 Australian neurologists. On the left is Dr. Bronwyn Jenkins up in Sydney. On the right is Dr. Trudy Cheng down in Melbourne, who contributed to these guidelines. Okay, so first up, for people who have migraine, less than 15 migraine days a month, this is the evidence that the expert group put together. And I've just highlighted here that the expert's strongest recommendation, teed up with the highest evidence from clinical trials, supports fremanezumab and galcanezumab for this group of people. It should be said for clarity, I've only included in the tables the medications that are currently available in Australia. There are some other options from medications available internationally. Then if you have 15 or more migraine days a month, which is the definition of having a chronic migraine, again, the advanced therapies, which includes the Botox therapy as well as the anti-CGRP monoclonal antibodies, have the highest level of clinical evidence and the strongest recommendation from experts for use in that group. So let's have a look now to finish up at advanced therapies. Onabotulinum toxin A, or Botox, is a purified neurotoxin. It works by blocking nerve signals from the nerve ending to the muscle, which then affects the ability for the sensory nerve to propagate a signal. And this injection, it's given as injections 12 weekly. People receive 31 injections around the forehead, the sides of the back of the head, and the neck. The injections are in very specific places around these areas with a specific unit of Botox in each area, and that was determined by the PREEMPT trials, which were done about 15 years ago. And the PREEMPT trials showed that using this specific course of Botox injections regularly resulted in significant reduction in headache days, headache-related disability. It improved people's function and quality of life compared to placebo. On the right is a graph from the PREEMPT trials. The y-axis, which is a vertical line there, shows a greater reduction in cumulative hours of headache. So you can see it's negative 50 hours of headache compared to baseline. The red line is the Botox, the grey line is the placebo, and you can see that there is a significant difference in terms of greater reduction in headache hours at each time point for the Botox group compared to the placebo group, and that out to 24 weeks, that impact is sustained. And then anti-CGRP monoclonal antibodies are our other advanced therapy in Australia. Calcitonin gene-related peptide is what CGRP stands for. It's a neuropeptide, which is like a chemical messenger. It's released when the trigeminal nerve is activated. Anti-CGRP monoclonal antibodies bind the CGRP molecule. This is of all the available ones we have in Australia, and that prevents the CGRP molecule from docking in the receptor and activating pain signals. We have galcanezumab and fremanezumab, which are monthly subcutaneous injections. We have eptinezumab, which is a quarterly intravenous infusion, so you need to go every 3 months to your local medical daycare unit to receive that. These medications are effective. They have sustained long-term benefit. We've got up to 5 years of real-world data from Europe, the UK, and the US now, and they're well tolerated. They reduce migraine frequency and improve quality of life. They're generally, although side effects are generally quite low, we have noticed in the post-marketing era that there can be constipation. So we tell patients about that to keep up water, fluid, and high fiber and exercise. And we also monitor the blood pressure, particularly with people who already have high blood pressure, particularly after that first infusion. So let's finish up with some Australian real-world data. Again, the study was led by Dr. Jason Ray, and it looked at a combination of people who had started anti-CGRP monoclonal antibodies across 2 Australian headache clinics. With a total of 105 patients, a median age of 42 years, who had failed on average 5 medications prior to starting the anti-CGRP monoclonal antibody and had on average 30 headache days a month, which is pretty severe. This group, they're over the 50% responder rate, which means that you have had a reduction in your headache days of half or greater, was 52.4% at 3 months. And that was sustained for this group at 12 months. So putting it another way, around half the people in the study, on average you had 30 headache days a month, had 15 or less headache days a month after starting the anti-CGRP monoclonal antibody, which is substantial given that this group haven't had a lot of luck with the previous preventers they've tried. At 12 months, a quarter of the group ceased it because it just didn't work for them, and 16% ceased it because of side effects. But for the group who were continuing treatment, 80% were experiencing now 18 less monthly headache days compared to baseline. So that's a substantial reduction in migraine. People who were at risk of not responding to the anti-CGRP monoclonal antibody were people who had a continuous headache at baseline. So there was no pockets of crystal clear time, and who had tried 4 or more preventers at the time they were taken up their anti-CGRP monoclonal antibody. Having said that, certainly in our clinical practice, we've seen people who haven't had a lot of luck for decades of trying different preventers having a really impressive response to the anti-CGRP monoclonal antibodies. So I would definitely suggest having a discussion with your GP or neurologist if this is something that you'd like to discuss further, and seeing if you would meet the PPS criteria to qualify. Thank you so much for your time, and I look forward to meeting you and going through some questions and answers.
First of all, thank you, Dr. Emma Foster. That was absolutely incredible. A huge amount of information to take in. So I'm sure these questions will help recap some of those insights. Right off the top, we have a question. Is there evidence that the CGRP medications can lose effectiveness over time as the body adjusts?
That's a really good question, actually. We think migraine is pretty dynamic. It's certainly very complex. We know that there are many different receptors and triggers involved in the migraine pathway, and it varies between individuals, but we also think it varies within the lifespan of that individual. I was having just a little look through the literature in the break there to have a look at that. We have got a meta-analysis of randomized control trials, which is probably about the best quality evidence that we can get, that basically is synthesizing results of well-designed, high-quality studies together. And this study was published in Kephalelgia 2023, which is, Kephalelgia is a mouthful, but it's a medical Latin word for headache. They managed to get 4 studies that fit their inclusion criteria of about 2,400 patients. They found that for a small number of people with chronic migraine, there was a wearing off effect of galcanezumab, which was the anti-CGRP monoclonal antibody that they examined there. There's an Australian study, and this is the one that was just in the last few slides of my presentation. So just to recap the real-world data within Australia, and this is published in 2024, they looked at 105 patients that had been started on any anti-CGRP monoclonal antibody, and they followed them up for 12 months. They found at 3 months about 50% of people had experienced a 50% or greater reduction in their migraine days. So that means if people came in on average, say, with 28 migraine days a month, half of that cohort would be experiencing 14 or less migraine days a month at 3 months. And then at 12 months, about a quarter of the group had stopped the CGRP monoclonal antibody because they had just found it not to be effective. So I hope that sort of gives you some real-world data about what we're finding, but we're certainly keeping track with the real-world prospective studies to find out what people's experiences are.
So they're not a cure for everyone. They don't work for everyone, but they are some of the best classes of preventive treatment for a lot of people. And then for those that it does help with, it can be very helpful.
It can indeed. I think, Carl, we're still understanding the physiology, which is the biology that underpins migraine. And anti-CGRP monoclonal antibodies, while people are taking them, seem to have a disease-modifying effect, as you said, for a good group of people. But we know in studies where people have come off the anti-CGRP monoclonal antibody for 4 to 5 months, there's often beginning to be a rebound or return of migraine. So it hasn't made a permanent change in the underlying migraine tendency for a lot of people.
Catherine asked, is there any word on whether the government is considering covering more than one injectable treatment under the PBS? So, for example, could they use a Botox injection with a CGRP combination?
It's such a good question. We certainly know from trials, and some people know from anecdotal experience, that if you combine Botox, which is one mechanism of action, with an anti-CGRP monoclonal antibody, you often have an extremely effective combination for migraine control. But largely because of the expense of these therapies, the government will support, for eligible people, one of these classes of advanced therapies, but not two at the same time. So typically people may be eligible and they'll pick one on the PBS and they'll pay out of pocket for the second one. I'm not aware at this stage, and Carl, I know your role as president of Migraine and Headache Australia is often in the advocacy space. I wondered if you may have heard any news about that.
So we've seen in the US that the insurers are starting to cover it. There's not sort of a national insurer in the US like there is in Australia with the PBS. And this is kind of one of the advocacy sort of requests that we have and that we need to put forward to government. The first goal was to get them approved, and that's now been the case. And we know that it's kind of a penny wise, pound foolish approach to sort of try to save on cost at from a government perspective, but still not give kind of the potential relief that might otherwise be experienced by people to benefit from them. So yes, it is something we definitely want to see. And I think we've really got to push the agenda. Like, it's not going to happen. I don't think they're going to proactively recommend it to us. We have to sort of ask for it and lobby for it.
I think that's, I really liked your phrase there, penny. I haven't heard this before, but it makes sense, penny wise, but pound foolish. There was a health economic analysis done on what does migraine cost in Australia per year. And I mean, in one hand, I guess it's not seeing the full picture of the impact, because it's not just taking people out of the workplace. Migraine obviously has far more extensive impact on people and families and society than that. But if you just looked at it from an economical cost, people having days off work or not being able to be their normal productive self because of a migraine attack, that costs Australia around $35.7 billion per year, which is an awful lot of money. And that's probably an underestimate, just because of the prevalence used for migraine was probably about half that of what the true prevalence is.
Rosemary had a question about, she said that she's had migraine and headache for many years, and she struggles to know whether she's having a migraine or a headache, and therefore not knowing what treatment to use during an attack, especially on those sort of yellow days that you spoke about. How might she differentiate or approach that management?
Such a good question, and I think a really good question there. migraine is a very distinct type of headache, and the features that we look for is a unilateral, which means one-sided, but it can be both sides, but often worse on one side than the other. Throbbing or pulsating quality associated with nausea, which is that feeling of needing to be sick or actual vomiting, and sensitivity to light and sound and motion. And migraine can sometimes be a more mild form, and oftentimes people living with migraine, they put up with a lot, right? And the attacks that are really horrendous and sort of mean they have to go and lie down in a dark room, they're like, that's my migraine. And anything that's a little less than that, and they're able to continue on with working, although it's not, it's not pleasant, but they soldier on. They say that maybe is not so much a migraine. So I think it really comes down to a very careful history between you and your GP or your neurologist to try and tease out, are there any, even if they're mild, are there any associated migrainous symptoms with these headaches? What's the nature of these headaches? Are they a milder form of what you call the migraine attacks? Because you might well be having just milder migraine attacks on the days that are currently being counted as headache. And that might make a big difference in terms of your treatment. It might push you from being someone who's just on lifestyle intervention and acute therapy to perhaps also being on a preventer, which can in the long term reduce the migraine frequency, severity, and intensity as well. But unfortunately, as everyone probably online knows, we don't have a brain scan or a blood test that we can do that will positively say this is migraine. The diagnosis is clinical, which means it rests on the history and on the absence of any other obvious causative factor.
If a Jovi or another CGRP treatment for that matter has been effective in reversing chronic migraine back to episodic, how long would you continue taking that treatment after you've sort of getting that benefit?
Great question. This is going to be really dependent on the individual and what their migraine was like prior to going on the anti-CGRP monoclonal antibody, what other options they've previously trialed, and also what's happening in their life at that stage, right? Is this a good time to be coming off medication or not? At the moment, we have expert opinion as opposed to robust studies to guide us. Expert opinion can say you could consider coming off it between about 12 to 18 months. But again, that would be a very individualized discussion between yourself and your doctor.
Deb asked if there's any research being done on nerve decompression surgery or migraine surgery.
So nerve decompressing surgery typically is when we've done neuroimaging and we can find that there's structures up against some of the major nerves that are part of the pain pathways. In conditions like trigeminal neuralgia, where oftentimes you can see that the trigeminal nerve is right up against a blood vessel, we know that microdecompressive surgery can help. Sometimes it's more temporary than permanent, but in reducing some of that pain. That's a separate condition from migraine. I have looked in, I've been keeping an eye on the questions, and I did have a little search during the presentation, but I haven't found robust evidence for this intervention for migraine. I think I'll keep my eye open for that.
Yeah. How do you balance going early with acute medications and balancing overuse of treatments when you're not sure if you'll get a full-blown attack?
Also a really good question and quite a difficult one. A lot of people I care for ask me the same thing. I think it is hard to know like how bad the attack is going to be in the early stages for a lot of people. And it's hard because you also need to take your acute therapy early in order for it to be most effective. I'd say it's good to start with your migraine diary and have a few months of consistent data to just see how many days you are beginning to get a migraine attack, never mind the consistency. And that will be a very good guide as to whether you'll need a preventer. Ultimately, if you're on a good preventer that works well, it will begin to reduce the total number of attacks you have. So the attacks that do come through would be the ones that you would begin to take your acute rescue therapy for. Certainly keeping an eye on it. If you realize more than 2 to 3 days a week you're needing to have an acute rescue therapy, that's a really good time to have a chat with your your healthcare provider about potentially starting a preventer therapy.
Can you take if there's a limit on triptans, if it's 9 or so triptans a month, can you take other treatment acute treatments like an NSAID, like ibuprofen, for example, on other days as well?
Yeah, that's a great question. So, I think we also have to think about what you're treating. Migraine attacks often last more than a few days, and people often then begin to wonder, do you keep taking it for the same attack or does it not work? So, in terms of combining the therapies, we really think early is good, and combination therapy of NSAIDs, like naproxen, for example, can be very effective in combination with the triptan, especially if you've found in the past that a single therapy is only partially effective. In terms of specifically talking about naproxen, which is a long-acting anti-inflammatory medication, it's quite neat because often the triptan's effect will start to fade within a few hours, but the naproxen on board will start to kick in at that point in time. So it's an effective combination. I think overall, though, the number of days you're using the acute rescue therapy is a really good indication of whether or not it's time to discuss starting preventer.
Lisa had a question and she asked this question last night. She's been very patient waiting for an answer. She's desperate to know if there's a migraine medication that also helps with sleep. She's tried propranolol, Periactin, amitriptyline, lamotrigine, Centimigraine, candesartan, and many others. She has Botox quarterly and monthly Ajovy.
Good question. Sleep is tricky, and actually a lot of our migraine preventers as a side effect can cause drowsiness. So, for example, she mentioned there amitriptyline, which we often say just take at nighttime, otherwise people get too groggy to do their daily activities. A medication not on that list was melatonin, and this is a natural hormone that is made by your body that can help with the sleep cycle. And there is some evidence for it as a migraine preventer as well. So that could be something to discuss with your healthcare provider if that sounds like a dual issue that you'd like to attend to.
Do you ever sort of recommend antihistamine in some of your patients?
Yeah, so we've got a medication called cyproheptadine or Periactin that's been around for a long time, that can be used as a migraine preventer, and it has additional benefit. People find, particularly around this time of year when they're getting hay fever, that often that's a lot better as well.
Andrea had a question about what magnesium is best for migraine and the dose.
Yeah, so with magnesium or the natural supplements there, generally the evidence is not super strong for it, but around 300 milligrams daily seems to be in some of the trials the dose that's being used. There are various supplements that have magnesium. I think one of the important things to note, often people do take supplements, a range of supplements for wellness, and what's on the title label, like Women's Health, might not perhaps tell you everything that's inside. So whichever vitamins or supplements you're taking, do take it to your pharmacist, your healthcare provider, just to check that you're not unintentionally taking over the recommended daily intake for a lot of these supplements, because they can be toxic at high levels.
Yeah, and I know that tomorrow we've got Dr. Fred Cohen who's going to be talking about complementary and alternative treatments and therapies, and he talks about magnesium specifically and doses and types. So that's at 11 a.m. tomorrow. It's not tomorrow night. It's tomorrow just before lunchtime, 11 a.m. Australian Eastern Standard Time.
That sounds like a great webinar, Carl.
Yeah, no, we're really looking forward to that one too. I know we're coming up towards the top of the hour. We're going to answer a few more questions. Emma, Dr. Foster, you've been absolutely fantastic answering so many different questions, like rapid fire. We'll do just a few more before we wrap up. Emma had a question about long COVID and the new onset of migraine. Is there a link? Can COVID cause migraine?
Yeah, that's a great question. I guess we're still working through our data, but at this stage, it looks like COVID certainly can cause headaches similar to migraine, and it certainly can worsen existing migraine for people as well.
What is the mechanism between stress and stress causing migraine?
That's a really great question, right? And a really hard one to answer from a scientific point of view on the basis, how do we measure stress? Because we know within ourselves, people do come across quite stressful events. Sometimes they'll have a profound impact on people, and other times they won't. And it's unlike, say, for example, blood pressure or cholesterol levels, where we have like a blood pressure cuff, we've got a blood test for cholesterols. We don't really have a reliable and robust way to measure stress for a person and then to have the effect, and then to sort of correlate that to the effect on the migraine. But what I would say for sure is that lots of people I see in my clinic report that their migraine flares during times of stress or sometimes after the stressful event has subsided.
Excellent. Well, thank you so much, Dr. Emma Foster. It's been an absolute pleasure. You are a wealth of information. I know a lot of people really enjoyed tonight. We've got um, we've got more experts coming, more headache specialists coming. So if you didn't get your question answered tonight, we will do our best to get those answered on subsequent webinars. And tomorrow we've got alternative and complementary treatments and therapies with Dr. Fred Cohen, who's a US headache specialist. And we've also got Living Well with Migraine with Dr. Bronwyn Jenkins, who's a member and leader within the Australian New Zealand Headache Society on Thursday night. So there'll be more opportunities for getting those questions answered. But thank you very much, Dr. Foster, and thank you for everyone joining us, and good night for now.
Thank you for having me. Good night, everybody.